Hi everybody. Today's lecture is about solid oral modified release dosage forms and drug delivery. This lecture is based on the reference of Ansels of Pharmaceutical Dosage Forms and Drug Delivery Systems, the 11th edition, chapter 9. After this lecture, the student should be able to define and state reasons for modified release dosage forms, describe the advantages and disadvantages of modified release dosage forms, distinguish modified release, extended release, delayed release, repeat action, and targeted release. List physical chemical characteristics of drugs that make them candidates for an extended release dosage form. Explain coating beads, multi-tablet, microencapsulation, embedding, complex formation, ion exchange, and osmotic pumps as these apply to modified release dosage forms. List USP requirements and FDA guidance for modified release dosage forms. Describe clinical considerations in the use of oral modified release dosage form. Describe packaging and storing modified release tablets and capsules. In order to facilitate you in having the big pictures about the lecture, this is the lecture outline. In the lecture outline, you will see there's several topics. One, what are modified release dosage forms? The introduction will include terminology, the rationale why modified release dosage forms should be used. 2. Advantages and disadvantages of extended release dosage forms over conventional forms. 3. Abbreviations in solid oral modified release dosage forms. 4. Drug candidates for extended release products. 5. How to modify the rate of drug release from solid dosage forms. 6. Extended release technologies for oral dosage forms. Under topic 6, there will be several technologies for oral dosage forms. 7. USP requirements and FDA guidance for modified release dosage forms. Under topic 7, we will focus on 3 subtopics: drug release, uniformity of dosage form, in vitro, in vivo correlations, or IV/IVC. 8. Clinical consideration in the use of oral modified release dosage forms. 9. Packaging and storing modified release tablets and capsules. First of all, we enter to the introduction about modified release dosage forms. Modified release dosage forms have drug release features based on time, course, and/or location that are designed to accomplish a therapeutic or convenience objectives that are not offered by conventional or immediate release forms. Remember, when we talk about conventional, that means the immediate release forms. The modified release dosage forms provide either delayed release or extended release. Please note that most of the modified release products are for oral tablets and capsules. Besides oral tablets and capsules, there are other types of modified release dosage form for ocular, parenteral, subdermal, vaginal, and transdermal products. These are some terminologies used in the modified release dosage forms. The first one is about extended release products. These products release the drug in a controlled manner. The drug can be released at a predetermined rate, duration, and location for the optimum blood levels of drug. The second type is a delayed release of products. This one commonly are enteric-coated tablets or capsules. These kinds of drug can pass through the stomach without changing, release the drug in the intestinal tract, have the drug to avoid destruction by gastric fluids, have to reduce stomach distress by irritating drugs. Example, emicin or erythromycin. These are delayed release tablets or erythromycin delayed release capsules. The third terminology is a repeat action. Repeat action contains two single doses of drug, the first for immediate release and the second for delayed release. Example, Repetabs. Repetabs had two-layer tablets for repeat action. The first layer will release the drug immediately in the stomach, and the second layer will have delayed release. The drug will not release in the stomach, but it will release in the intestine. And the fourth terminology is a targeted release. This kind of drug released directly toward isolating or concentrating a drug in a body region, tissue, or site for absorption or for drug action. Example, Tabrecta or Capmatinib. The drug is approved in 2020 by the FDA for the treatment of adult patients with non-small cell lung cancer or NSCLC that has spread to other parts of the body. This drug will work targeted directly to the cell in the lungs rather than other cells. Why modified release dosage forms are necessary? Some drugs do not have long-lasting and require multiple daily long to achieve the desired therapeutic effects. Typically, conventional tablets or capsules can release the drug immediately. The drug can be released and have the fast therapeutic effects. However, it's associated with a short term of effects, so it requires to have many times of dose a day. This can be inconvenient for patients because taking the drug up many times a day, it can possibly cause the missed doses or some complicated makeup dose for the missed dose, and it can be non-compliant for some regimen. The development of modified release, or one of good example of modified release extended release tablets, can overcome the problems of conventional tablets. First, the extended release tablets provide less frequent use. Usually, the drug just need to use 1 to 2 times a day. It's very convenient for a patient. For extended release tablets, first of all, the dose will have the first immediate release. The first immediate release just acts like conventional release. Then the remaining dose will have the gradual release to maintain the effects over a predetermined period of time. Look at the graph here. This is kind of drug blood profile of a conventional dosage form. After one dose, the drug will go up to the maximum concentration, but then after reach equilibrium, the drug will be eliminated. And in order to maintain the concentration of drug within the therapeutic window, that means within the MEC or minimum effective concentration and MTC or minimum toxic concentration, then another dose needs to be taken, and then another dose will have to bring the concentration of drug to fall within the therapeutic window, and then another dose the drug will be eliminated too, and then another dose will be added, and so on. So in order to maintain the concentration of drug to fall within the window or within the therapeutic window, multiple doses have to be obtained within only like 12 hours. There's here in the example had 3 doses, at least 3 doses need to be taken. However, for the extended release drug, this is a graph to show about extended release profile. For the extended release profile, the dose, only 1 dose per 12 hours. First of all, the first immediate release will happen when the extended release drug is taken, and then the remaining dose still release the drug gradually with time, and it still maintain very stable concentration of drug within the therapeutic window. What are advantages of extended release dosage forms over conventional forms? First, the extended release can provide less fluctuation in drug blood level to compare with the conventional one. By controlling the rate of release,
It can eliminate the peaks and valleys of blood levels. Second advantage is the reducing frequency in dosing. By delivering more than a single dose, so for the extended release, the patient will take the dose less often as compared with the conventional, for example, just 1 or 2 times a day. Because of the less frequency, another advantage can be associated is the enhancing convenience and compliance from patient. So this can avoid missed doses or more convenient for patient, so avoiding night dosing, and that's one is more compliant for certain patient population, especially for children or for a senior patient. It can help reducing adverse side effects because by providing fewer blood level peaks outside the therapeutic window or provide very stable concentration within the therapeutic window, the adverse side effects can be limited. And the last advantage is reducing overall healthcare cost. By enhancing therapeutic effects of fewer side effects, this will take less time to dispense, administer, and monitor patient. So in overall healthcare costs, using the extended release dosage forms is more it can be saving more to compare with the conventional one. Although the modified release dosage forms has a lot of advantages, these dosage forms have some disadvantages. First is the loss of dose or regimen flexibility. Because the frequency of use is just 1 or 2 times a day, any adjustment will be limited. The second disadvantage is the prompt termination of therapy is difficult. Because this one has a long release, so any termination of therapy need to be waited until on the medicine or on the drugs is eliminated out of the body. And because it's a long release, long effect, so it takes more time for a modified release or extended release of drug to be terminated as compared to the conventional one. The last one is very important is the potential dose dumping. This happens when the whole dose of the extended release was released immediately for a short time. Because the drug was supposed to be released, maintain a release within 12 hours. But for some reason, the dose can be the whole dose will be dumped or will be released in the body, and it can happen within a couple of hours. So in this case, the drug concentration will be increased more than expected, and it can cause the toxicity. The causes for potential dose dumping can come from many reasons. It can be some mistake when the patient choke or break or do something to interfere with the medicine before orally swallowing the whole, or based on the storage or the transportation, the drug can be broken, chipping, or something happen to the coating that make the drug will be released immediately in the intestine or in the stomach. So that's why it make the drug the whole dose will appear in the blood within a short time instead of within a long time. In order to be candidates for extended release products, drug needs to have suitable properties. First, drugs must exhibit neither very slow nor very fast rates of absorption and excretion. Typically, the half-life should be more than 2 hours to less than 12 hours. If the drug has very short half-life, for example, less than 2 hours, this is very poor candidate for extended release. Second properties, drugs that are uniformly absorbed from the gastrointestinal tract. This means the drug has good aqueous solubility and have adequate residence time in the GI tract. Third property, drugs that are administered in relatively small doses. Fourth properties, drugs that possess a good margin of safety. This means the small dose, drug used in a small dose and has a large therapeutic index or large therapeutic window. And the last but not least, drugs that are used in the treatment of chronic rather than acute conditions. Basically, there are three methods to modify the rate of drug release from solid dosage forms. The first way is can be modifying drug dissolution by controlling access of biologic fluids from the drug through the use of a barrier coating. The second method, controlling drug diffusion rates from dosage forms. And the last method, chemical reaction or interaction between the drugs or its pharmaceutical barriers and site-specific biologic fluids. And these are typical extended release technologies for oral dosage forms: coated beads, granules, and microspheres, multi-tablet systems, microencapsulated drugs, embedding drugs in inert plastic matrix, complex formation, ion exchange resins, osmotic pump, or repeat action tablets. Now we go to detail of each technology for oral dosage forms. The first technology is a coated beads, granules, and microsphere. In this technology, the drug is included onto beads, pellets, granules, etc. And in, for example, for the capsule here, or the Spanzone capsule, in one capsule, in one single dose, there's contain different kinds of granules. Some granules, about 1/3 of amount in the capsule, are uncoated. So the granules can provide the drug immediately, and it can provide the release immediately after disintegrated. Other granules will have different coating, and the coatings can be like in different thickness. The coating can be wax, cetyl alcohol, plasticizer material, etc. Because the coating is different thickness, different materials, and blended together, these kinds of coating granules will release the drug in different time. So in one single capsule here, it includes some granules that provide immediate release, and some granules provide longer release or longest release. Because of the mixture of this one in the capsule, when it is administered to the body, it will create the first immediate release to have the fast therapeutic effects, and the remaining has the different release. It will maintain a sustainable or prolonged release or controlled release for the drug with time. Another technology for extended release is a multi-tablet system. In multi-tablet systems, there's a blend of different small spheroid, about 8 to 10 spheroid mini compressed tablets placed in gelatin capsule shell. Some mini compressed tablets here is uncoated, that will provide immediate release, and some mini tablets are coated to have the extended release. The next technology of extended release in microencapsulated drugs. In this technology, the drugs can be in solid, liquid, or gas. For the technology, the drug will be enclosed in a microscopic particle. For example, this is an example of the microscopic particle. The drug is in the center, and it is encapsulated by different material or layer outside. So the drug is like a core in the particle, and outside have different layer, and the layer has different function. It have to release the control of the drug. Advantages of this kinds of encapsulated drug is that the particle is small. Because small, so it has the large absorption. It enhances the absorption of the drug from the particle. Example of microencapsulated drugs are micro and extend caps. This cap capsule contain active ingredient is potassium chloride at a dose of 600 milligram per capsule. This is a picture of micro K extend caps. This one can release the drug over a long time as compared with the normal potassium chloride. And the encapsulation material or excipients are ethylcellulose, magnesium stearate, sodium lauryl sulfate, and some other excipient, color, iron oxide, titanium dioxide, gelatin, etc. The next technology is embedding drug in slowly eroding or hydrophilic matrix system. To make this case of extended release drugs, there's two kinds of granules. The first one is regular granules. Regular granules is composed of drug, excipients, and this kind of granules is for immediate release. Second type of granules is special granules. These granules include drug and excipients. However, the excipient is special. The excipients will provide slow erosion in the body fluids, and the composition for this kind of excipients usually hydrophilic cellulose or HPLC. This form a matrix. And these kinds of special granules will provide extended release. When they make these kinds of special extended release drug, they will mix two kinds of granules together, and the granules can be compressed to form tablets or can be mixed to fill into the capsule. This is an example of tablets embedding drug in slowly eroding or hydrophilic matrix system. The corner here is the yellow corner here is the drug. The special drug, the drug with special excipient or HPMC excipient is made like a matrix and is contained active drug in here. And the other layer, it can be a barrier layer. It controls the surface area diffusion of drug from the core. And to mix among this white layer here, it can be some kinds of immediate release drug and mixed together. So the whole system here in the tablet here is contains some drugs and excipient can for immediate release and some drug in the core for special control or extended release. The next special technique is to embed the drug in inert plastic matrix. Remember our previous slide shown that the drug is embedded in the hydrophilic matrix. For this case, the matrix is made from different material. That's a plastic, and it's not like hydrophilic; it's a hydrophobic. And as usual, any kinds of extended release, even embedding drug in inert plastic matrix, always contain some regular granules. Regular granules includes drug plus excipient for immediate release, and these kinds of granules usually are compressed on the surface of the tablet. Then there are some special granules, and these special granules include drug and inert plastic materials, for example PE or PVA. These kinds of plastic will be coating the granules and then compressed in the center of the tablets. Two of them will be mixed together. Two kinds of granule will be mixed together to form the tablet. And the immediate release will be released to provide a kind of fast action, and then the remaining special granules will have the control of prolonged release to maintain the drug concentration within therapeutic window for a long time. And for this release here, the drugs is slowly released from the inert plastic matrix, mostly by passive diffusion. Example for these technologies is a gradume made by the Abbott. Another technology to make extended release is making complex formation. For this case of technology, the drugs will be included with excipients, for example, salt of tonic acid, or tannate, etc., to make a complexes. And this complex may be slowly soluble in body fluids, and the solubility will be dependent on the pH. Example for this complex of formation is Ranitol tablets. This kind of antihistamine for nasal decongestant combination. Each tablet contains phenylephrine tannate, chlorpheniramine tannate, and excipients like cornstarch, D-basic, calcium phosphate, methylcellulose, magnesium stearate, polygalactouronic acid, povidone, talc, etc. The next technology is the ion exchange resins. This technology is applied only to cationic drugs. Doesn't mean the drugs has a positive charge. For this technique, the drugs will be passed through a column containing an ion exchange resin. So based on the exchange resin, the drug from the pure drug will complex with the resin to form a resin-drug complex. This complex will be washed, tableted, encapsulated, or suspended into an aqueous vehicle. And the vehicles used in or excipient using this technology are usually polymer barrier coating and using bead technology. Example, the resins with some kinds of carboxylic acid or some kinds with sulfate acid. The drug release of this kind of drug depends on the pH and electrolyte concentration in the GI tract. And normally, the drugs are released greater in stomach due to the influence of acidic fluid. Example for this kind of technology is anamine 15 capsule. This kind of drug contains phentermine resin. The phentermine resins in the drugs after passing through the resin column, it will have a complex like this, and this complex will be tableted or will be compressed into kinds of granule, and this granule will be inserted into capsule. Inactive ingredients included using for this kinds of technology for anamine, the basic calcium phosphate, lactose, magnesium stearate, some color, iron oxide, titanium dioxide, and gelatin. One of the most advanced in technology to make extended drug delivery system is osmotic pump. This kind of technologies is to create some advanced tablets to control the release of drug over time. Technically, the tablets has some kinds of appearance like this. The drug has the tablets had two main parts. That's the core and the layer. In the core, in the course of a section there are two main layers. One layer contains the drug, and one layer contains the polymeric osmotic agent. And this acts as a osmotic pump or push layer. The core tablets is encapsulated by inner layer, and this inner layer is made from semi-permeable membrane. This semi-permeable membrane has a coating with a special material, and on the surface of the semi-permeable membrane has a hole. Usually the hole has a diameter around 0.4 millimeter, and the hole is made from a laser beam. So the tablet includes the core tablet and the semi-permeable layer outside, and in the tablets between connection between the core tablet and semi-permeable, there's a hole, a diameter about 0.4 millimeter. How the drugs can be released out of osmotic pump? When the tablet is swallowed and it will go to the GI tract, then with the influence of the body fluids, the semi-permeable membrane here will allow the water to enter from the patient's stomach to the core tablet. Permeable, this membrane we call semi-permeable membrane because it allows the fluid outside to go inside the tablet. So the gastric fluid can penetrate inside the tablet. However, it won't get the fluid inside the tablet go outside through the semi-permeable membrane. That's why we call semi-permeable. Doesn't mean it's just a half permeable. So again, after the tablet swallow, the drug will be disintegrated, and then with the influence of the body fluid, the semi-permeable membrane will allow the water to enter from the patient's stomach into the core tablet. And when the water enter in the core tablet, it will dissolve or suspend the drug inside. And the drug inside here, when the volume get more and more, it make the volume in the core tablets increase. The pressure increase too. And when the pressure increase, what happened? With the large pressure increase in here, it will pump the drug solution. It will pump out the drug solution in the core out of the tablet through the hole here. The hole here also called the orifice hole. This called a hole or it's called orifice. So whenever the drug is dissolved here, the solution will be pumped out. And then solution is pumped out of the tablet here. It will continue go to GI tract and absorb, and then pass the liver and then go inside the blood system. Remember, only the drug solution or suspension or liquid created inside the core tablet can pass through the hole in the tablet. The undissolved still remain in the tablet. With the time, within like each hour, only a few drops of water can withdraw or draw into the tablet. Just the semi-permeable can control how much the water can get inside. So within an hour, just small amount of water can get inside, small amount of drug will be dissolved and then pumped out of the body. So with the time, small amount will be dissolved and small amount will pump out. So it will make a controlled release of drug with the time. The rate of inflow of the water and the function of the tablet depend on the osmotic gradient between the content of the two-layer core and the fluid in the GI tract. And it depends on the thickness or the composition of the membrane and the diameter of the drug release orifice here. For this kind of drug release system, the drug release is not affected by the GI tract or by the pH or by the fat condition or GI motility. It's independent in many factors in the body, and it creates a very effective osmotic pump to release the drug with time. An example for osmotic pump delivery system is a Glucotrol XL. This contains clipizide tablets. Active ingredients are clipizide. This is a drug using for the treatment of diabetes. The excipients for these kinds of pump osmotic drugs are control release a GITS osmotic system. This includes a polyethylene dioxide, hydroxyl propylcellulose, cellulose acetate, etc. And as mentioned or described in the previous slide, the drug includes two main sections, the core and the semi-permeable membrane. On the surface of the semi-permeable membrane, there's an orifice or hole. So when the drug is administered to the body, the water from the stomach or the gastric fluid, etc., from the body will be drawn into the core tablet through the semi-permeable membrane, and it will dissolve the drug inside. With the increasing of the water here, the volume here will be increased, and with volume increase the pressure, and then when the pressure increase, will pump out the solution out of the orifice release or the hole here. And with the time, the drug will be dissolved and then pumped out with the time, so it can control the release of the system. As a conventional delivery system, the extended release system has to undergo different tests and need to pass the test and requirement from USP as well as FDA guidance. For the modified release dosage forms, there's some additional or more focused testing requirement as compared to conventional one. The important tests for the modified release dosage forms can be drug release, uniformity of dosage units, in vitro, in vivo correlation, and labeling. About drug release requirement, USP tests for drug release for extended release and delayed release dosage forms are based on the drug dissolution from the dosage unit against elapsed test time. This is an example about aspirin extended release tablet. For example, for the time 1, 2, 4, and 8 hours, amount is on. There's some requirement that need to be met. For example, after 1 hour, about 15 to 40% of aspirin in extended release must be dissolved. After 2 hours, there should be 25 to 60% and so on. And drug release is also used the same system of dissolution testing. About requirement for uniformity of dosage form, USP standard for uniformity is similar for conventional dosage form. The uniformities in weight variation and the content uniformity does mean the amount of drug in each dosage. About in vitro, in vivo correlation or IVIC requirement, the test is required and critical for oral extended release products in various phases, in product development, in clinical evaluation, in submission for marketing approval or for post-approval. And there's 3 levels of IVIC, A, B, and C. And different level, they have different requirement about the correlation between in vitro and in vivo tests. It's important to know clinical consideration in the use of oral modified release dosage forms to ensure the safety and efficacy on patient use. About patient counseling on extended release products, do not use interchangeably or concomitantly between the extended release and immediate release products. Should not crush or chew extended release products. For the non-erodible plastic matrix shell and osmotic tablets, some remain intact throughout the GI transit, so the patient will see some empty shell or ghost form of osmotic tablets in the stool. So if when the patient takes any kinds of drug that have the plastic matrix shells or osmotic tablets, the pharmacist should consult the patient about the presence of these empty shell or ghosts from the stool and make sure that the patient know that that's normal. Do not change, stabilize the patient from extended release to immediate release product if there's no clear about existing blood level concentration of the drug, because the sudden change can make the drug can be reduced or increase the maximum concentration, and it can be like within or outside of the therapeutic window. Do not change or stabilize the patient from an extended release to another extended release. In order to exchange 2 kinds of extended release, the drug needs to have equivalent of bioavailability. Do not crush, open, etc. the modified release tablets or capsule for extemporaneous compounding. Remember, all the kinds of modified release dosage form cannot be crushed, opened, or chewed. For patients who are being fed by enteral nutrition through a nasal gastric tube, so for the patient may receive either conventional or modified release drugs. For the package and storing of modified release tablets and capsules, the condition similar as the conventional drug. In summary, modified release dosage forms provide either delayed release or extended release. The modified release is to provide less frequent use, convenience, and maintain therapeutic effects. Modified release dosage forms have advantages in providing less fluctuation in the drug blood levels, reducing frequency in dosing, enhancing convenience and compliance, reducing side effects, and reducing overall healthcare cost. However, these dosage forms can have loss of dose flexibility, difficulty in prompt termination of therapy, and a potential dose dumping. Modified release can be delayed release or extended release. Extended release does mean the drug release in a controlled manner. Delayed release, the drug release is delayed until the drug reaches certain site. Repeat action contains a 2 single dose of drug for first immediate release, then second dose for delayed release. Targeted release is the drug release directed toward targeted sites in tissue, etc. Drug candidates for extended release products must exhibit neither very slow nor very fast rates of absorption or excretion, be uniformly absorbed from the GI tract, be administered in a relatively small dosage, possess a good margin of safety, and be used in the treatment of chronic disease. Various extended release technologies are applied for oral dosage forms, such as coated beads, multi-tablet, microencapsulation, embedding, complex formation, ion exchange, and osmotic pump, as these apply to modified release dosage forms. USB requirements and FDA guidance for modified release dosage form consists of drug release, uniformity of dosage units, in vitro, in vivo correlations, and appropriate labeling. Clinical consideration is using oral modified release dosage forms include providing patient counseling, keeping stabilized patient in using same extended release, or be careful when changing from extended release to immediate release or from one extended release to another extended release. No crushing or opening of this kind of dosage forms. Packaging and storing modified release tablets and capsules are the same as for conventional products. That's all for today's lecture. If you have any question, please email me or come to my office during the office hours. Thank you for your attention.